Hi everyone, I'm Tom Fusillo. I'm a second-year internal medicine resident, and this is the second part of a mini-series on diffuse large B-cell lymphoma. So in this video, we'll be talking about treatment options for DLBCL. When I tell you, keep in mind, every patient's different, and these things are constantly changing as far as treatment guidelines, and different oncologists also have different preferences. So this is by no means a panacea. It's just an overview of some treatment options and some things you might see along the way in DLBCL. So I hope you enjoy. All right, so let's get into part 2 of DLBCL, and we're going to be talking about treatment. Let's start with a little overview of treatment of DLBCL. So this is a somewhat large and complicated flowchart that I created just to give an overview of the treatment pathway in this disease. Now remember, every patient is different. There's always going to be some variation from any one standard pathway. And this particular one is based primarily off of the NCCN guidelines. So we start over here with staging, right? So you have your patient, you stage them, and you begin therapy. Whichever therapy you'd like to start, you start it. Okay, and you give them a few cycles. You give them 2, 3, 4 cycles, and then you stage them again. So you restage them with a PET scan. At this point, you're going to restage them. You're going to see either a complete response, a partial response, or the progression of disease, POD. Let's say you have complete or partial response. You're then going to complete the therapy. In partial, you might obtain a new biopsy. But either way, if you have a CR or a PR, you're going to complete the first line of therapy. Now, normally, therapies might be, say, 6 cycles. So that'll show you do about 3. So you finish about half the therapy, you restage, and then you finish the rest. So if you give them another 3 cycles, for example, so you had a total of 6, you're done with first-line therapy. If they're still in complete response, which hopefully they are, hopefully they should be if they were initially, then you just go on to complete response monitoring. Now, if they have partial, you finish first line, you're going to restage them again. And if there's progression of disease or there's not complete response, we're going to go on to a second line. You should have a new biopsy at this point. And this point is where you really need to decide, is this a patient that you want to take to transplant? If they are, you can do a second line systemic therapy. So let's say you did R-CHP, and maybe now you want to do dose-adjusted EPOCH-R. All right, so that's your second line. So you come up here, do they have a response, complete or partial? Depending on that is where you're going to go next before your transplant. You can do a high-dose therapy plus a transplant. They have complete response. If they're not a complete response, this is where you can also consider CAR-T. And to begin with, if they're not a transplant candidate, maybe their age, functional status, what have you, you can do a trial, you do second-line, palliative, radiation, and at that point, you're kind of a limited options, third-line trial, palliative again. So let's get into some specifics here. What are some of the first-line systemic therapies? So there's a few main ones. The first is R-CHOP, and this is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. You have Pola-R-CHP, which is polatuzumab vedotin, rituximab, cyclophosphamide, doxorubicin, and prednisone. Then you have DA, which is dose-adjusted EPOCH-R, which is etoposide, prednisone, vincristine, cyclophosphamide, doxorubicin, and rituximab. And additionally, with any of these, really, you could have a substitution of a drug called obinutuzumab for rituximab. They have the same mechanism of action. So let's get into specifics on the story behind how we treat DLBCL in general. So, how did R-CHOP come about? Well, before the 2000s, one of the standard therapies for DLBCL was just CHOP. So Caulfier et al. Compared CHOP to R-CHOP as first-line therapy in DLBCL. And in this study, all patients were at least 60 years old. They were all at least stage 2. And they compared 8 cycles. So they had 8 cycles of CHOP or 8 cycles of R-CHOP. And what they found was that the complete response in R-CHOP was 76% compared to 63% in CHOP, and this was significant. So we look down here, your probability of event-free survival. And in this study, they defined events in event-free survival as progression, relapse, and death. So the probability of the event-free survival, you can see here, CHOP clearly below the R-CHOP line, and this was significant. Over here, we see the overall survival, and again, the CHOP is below R-CHOP with a significant p-value. Importantly, this study did not differentiate between DLBCL subtypes. And another important note, there was no significant increase in toxicity. So let's talk a little bit more about R-CHOP. Traditionally, days 1 through 5, you get prednisolone, and day 1 is when you get the rest of the drugs. So day 1, you get the rituximab, cyclophosphamide, vincristine, doxorubicin, and prednisone. And then 2 through 5, you'll get just prednisone. Typically 21-day cycles. There have been some studies that looked at shortening this, say, and make it 14-day cycles, but didn't show any real benefits to shorten to 14. So it's 21-day cycle typically. And here, CEN and all compared 8 versus 6 cycles of R-CHOP as the first-line therapy in DLBCL. More specifically, they did 8 cycles of R-CHOP versus 6 cycles of CHOP with rituximab, and then an additional 2 of just rituximab. In this study, all patients had an IPI greater than or equal to 2, or an IPI of 1 that was not due to age alone, or an IPI of 0, but they did have bulky disease. And what did we find here was the 3-year progression-free survival in the 6-cycle group was 69% versus 67% in the 8-cycle group. So that means there was no significant difference in this 3-year PFS in 6 versus 8 cycles. And actually, what we found too was when it came to 3-year overall survival, the 6-cycle R-CHOP actually had a higher 3-year overall survival than 8-cycle R-CHOP, and that was significant. And so here what we're looking at is the 6 versus 8 line and the survival probability, very tight. Another important note here was that the rate of the grade 3 to 5 adverse events was 18% in the 6 cycle versus 39% in the 8 cycle. So it makes you think perhaps the better overall survival in R-CHOP 6 could be partially due to less adverse events than the 8-cycle R-CHOP. And again, later on, Wastrelid et al., they replicated these findings with a true 6 versus 8-cycle R-CHOP. So the 6-cycle was actually just 6 cycles of both rituximab and CHOP. What about O-CHOP? Like we said before, obinutuzumab can be substituted for rituximab in many of these. Obinutuzumab, same mechanism of action as rituximab, remember, CD20 monoclonal antibody. And previously, obinutuzumab had shown some greater direct cell death properties, as well as antibody-dependent cell toxicity and phagocytosis activity than rituximab. So the thought process was maybe obinutuzumab is just a stronger rituximab. So what if we substitute it in some of these regimens? Would we get a better result? Sen and colleagues once again looked at this. They compared 8 cycles of O-CHOP to 6 to 8 cycles of R-CHOP as first-line therapy in DLBCL. In the O-CHOP, the obinutuzumab was given on days 1, 8, and 15 in cycle 1, and then just day 1 in cycles 2 through 8. In the study, all patients had an IPI that was high risk, high intermediate risk, or low intermediate risk. And what did we find here? The 3-year progression-free survival, 70% in O-CHOP, 67% in R-CHOP. That was not a significant difference. So they found no significant difference in 3-year PFS between these two regimens. Down here we can see the PFS graph here, very tight lines. And the same thing was with overall survival also. No significant differences. What they did find was the grade 3 through 5 adverse events were significantly higher in O-CHOP. All right, so let's talk a little bit about dose-adjusted EPOCH-R. So Bartlett and colleagues compared R-CHOP with dose-adjusted EPOCH-R as first-line therapy in DLBCL. It's important to note that in this study, the Bartlett study, high grade was excluded, so there was no double, triple hit in this. They compared 6 cycles of each. Most patients had either stage 3 or 4 disease. And what they found was the 2-year progression-free survival was 79% in dose-adjusted EPOCH-R versus 76% in R-CHOP. And that was not significant difference. So you can see the PFS graph here. The R-CHOP line is in red and the EPOCH is in blue. not a significant difference. We look at overall survival. We look at the 2-year overall survival is 87%. So pretty high in dose-adjusted EPOCH-R versus 86% in R-CHOP. Of course, once again, not significant, and that's the graph here. Very tight lines. You can sum that up and say that there was no significant improvement in either progression-free survival or overall survival between R-CHOP and dose-adjusted EPOCH-R. The grade 3 to 4 adverse events were significantly more common in the EPOCH group. This included infection, febrile neutropenia, mucositis, and neuropathy. And despite all this, it's still considered a more aggressive treatment option generally. And so sometimes this is actually preferred in high-grade lymphomas because this is, like I said, considered a more aggressive option. So because of that, Petrick and colleagues compared this and some other intensive first-line therapies to R-CHOP in patients with high-grade DLBCL, so your double, triple hits. This is a retrospective study, and what they found was there was significantly higher complete response in dose-adjusted EPOCH-R than there was in R-CHOP. And so this is why this is oftentimes considered in high-grade DLBCL. So the graphs here, what are we looking at? So A, this is just showing overall and progression-free survival across all groups. And then when we look at the PFS here in graph B, your R-CHOP is going to be this gray bottom line, and your EPOCH is going to be the blue. So you can see the EPOCH line is above. The other lines are other therapies that were considered intensive therapies. And down at C is the same thing, but overall survival. Again, R-CHOP down here is your solid gray, and dose-adjusted EPOCH-R is the blue here as well. So once again, intensive induction, which includes dose-adjusted EPOCH-R, was associated with improved progression-free survival, but not overall survival. Like we said, down in overall survival, you can see that the EPOCH line, which is the blue, is right on top of that R-CHOP. But up here with PFS, definitely a significant difference. Pola-R-CHP. Let's talk a little bit about Pola-R-CHP. Polatuzumab vedotin. It's a monoclonal antibody targeting CD79B, and Tilly and colleagues compared Pola-R-CHP to R-CHOP as first-line therapy for intermediate to high-risk DLBCL. This was an international phase 3 randomized double-blind trial, included patients with an IPI of 2 to 5. And importantly, this did include double or triple hit, as well as double expressor lymphomas. CNS patients were excluded, and this compared 6 cycles of Pola-R-CHP versus 6 cycles of R-CHOP with an additional 2 cycles of rituximab alone. So if you think about it, in this regimen, the polatuzumab essentially replaces the vincristine, which is the O in R-CHOP. What did they find? Well, they found that 2-year progression-free survival was 77% for Pola-R-CHP versus 73% for R-CHOP, and that was actually significant. You see the graph here, R-CHOP below Pola-R in those lines. The 2-year overall survival was 89 in the Pola-R-CHP, 89 in R-CHOP, so no difference there. No significant difference in overall survival, but there was a difference in the PFS, the progression-free survival. And when they did the subgroup analyses here, they saw that there really wasn't a clear benefit in young patients, so under 60. There wasn't really a clear benefit if you had the GCB subtype, and the same with bulky disease. So some interesting results. And when we look at actually the adverse events, they weren't too different. One of the big ones that I usually look for is the neutropenia, which when it came to overall and higher grades, so the grade 3 or 4, was both not higher than R-CHOP. So in other words, not a greater chance, not a greater risk, I should say, of neutropenia, including high-grade neutropenia in Pola-R-CHP when compared to R-CHOP. I want to switch gears and talk a little bit about CNS prophylaxis and treatment. So when it came to CNS prophylaxis, Ayer and colleagues performed a meta-analysis that showed no decrease in CNS disease at relapse in patients that were given intrathecal prophylaxis. In this study, most patients who received the intrathecal prophylaxis, though, were at higher risk of CNS relapse to begin with. So you could think maybe that is a confounder there. If we're only giving the intrathecal prophylaxis to patients who are at very high risk to develop CNS disease to begin with, does that confound the results? Maybe. But then Orellana and colleagues compared intrathecal to IV CNS prophylaxis with systemic first-line therapy in patients with aggressive non-Hodgkin's disease. This is a retrospective study. Patients included in the study were predominantly DLBCL, but there were some transformed follicular lymphoma patients. And a good amount of these patients actually had double hit as well. And what they found, there was no significant difference in relapse rates between intrathecal and IV prophylaxis. And this also held true for all subgroup analyses. You can see 7% IV relapse rate versus 5% intrathecal. This is not significant. You can see here, figure 1, and this is basically validating the CNS IPI. If you had a higher IPI score, you had a higher probability of CNS relapse. And they also noted that the rates of CNS relapse increased with multiple extranodal sites. So that's what figure 2 here is showing. As you have more extranodal sites, the risk of CNS relapse seems to increase as well. There's some other studies that have attempted to compare CNS prophylaxis to controls, and that also showed no reduction in CNS relapse. But nevertheless, CNS prophylaxis does remain somewhat common in younger and more fit patients, especially with high-risk disease. It still is done somewhat commonly. So when it comes to CNS therapy, there's a major trial known as the Marietta trial, and they looked at 3 cycles of matrix therapy, followed by 3 cycles of rice, followed by carmustine thiotepa stem cell transplant. So what are these? Well, matrix is rituximab, methotrexate, cytarabine, thiotepa, and rice is rituximab, etoposide, ifosfamide with mesna, and carboplatin. And what they found here was a 2-year overall survival of 46%. And the graph here on the right is showing that patients that were enrolled in the trial at initial diagnosis, they did much better than the patients who are enrolled at relapse. So patients that say relapse, and at relapse they have CNS therapy, they did much poorer compared to patients who had CNS at initial diagnosis. The reason that these therapies may look so different because, well, R-CHOP doesn't cross the blood-brain barrier, so you need alternatives to get through there. Primarily, methotrexate is one of those big alternatives. In the Marietta trial, though, the big downside was high rate of neutropenia, and there was even 5% that patients had treatment-related mortalities, and all of those were secondary to gram-negative bacteremia. And so while Marietta is often used as guidance, the NCCN actually currently recommends M-R-CHOP, which is high-dose methotrexate with R-CHOP. I'm going to finish talking a little bit about CAR-T, just a brief kind of overview of CAR-T and DLBCL. And what CAR-T therapy is, we basically freeze the patient's own T cells, and then they're engineered to recognize certain biomarkers as antigen. So in other words, you take the patient and freeze their T cells, you send them off to the manufacturer lab, and they will design those T cells to recognize certain antigens, which can be CD19, 20, 22, are some examples, as antigens. And then those T cells will attack the cells that have those antigenic markers. In DLBCL, typically, CD19 CAR T cells are used. And the overall response rate varies, but it's somewhere between 60 to 85%, let's say. But they have a durable, complete response of about 40 to 50%. And so it can be an effective treatment. The downside is, sure, your DLBCL cells have CD19, so your CAR T cells will attack those, but your normal B cells also have CD19 on them, right? So you have a side effect of B cell aplasia, which can last for years. And depending on the age of the patient, it could be lifelong. And if you have B cell aplasia, you're also going to have a hypogammaglobulinemia, right? Because you don't have the cells that are producing your immunoglobulins. So obviously that puts you at a much higher infection risk going forward. And another major adverse event that can happen that you really need to know about if you're talking about CAR T is cytokine release syndrome, or CRS. And this is kind of like a SIRS type picture, right? You have fevers, hypotension, hypoxia, you can have neuro changes. And this is really due to systemic release of IL-6. Remember, IL-6 is an acute phase reactant, and interferon gamma. And if it goes unchecked, this can progress to something called capillary leak syndrome, which can be fatal. Fortunately, now we have tocilizumab, or TOSI, is kind of what it's called for short, which is an IL-6 receptor antagonist. So that can be used to help treat the CRS as well as steroids. So I know that was a lot of data and graphs and everything like that when it comes to treatment, but I hope it gave you a good overview of some treatment options for DLBCL patients and understanding the thought process that might go into choosing which one you might go for in a DLBCL patient. So with that, I hope you enjoyed and hope you'll check out some of the other videos I have.